Welcome to this high-yield training explainer. I'm stepping into the role of your senior medical coding specialist today, and we're going to completely demystify the complex ICD-10-CM rules for cardiorenal coding. If you've ever stared at a multi-system patient chart and just felt a bit overwhelmed by the cascading rules of hypertension, heart failure, and kidney disease, well, you're absolutely in the right place. We're going to break down these guidelines so you can tackle even the toughest charts with total confidence. So let's just dive right in.
Okay, so here's our clinical to code pathway for this explainer. We're going to cover the foundation of hypertension and heart basics, staging chronic kidney disease, decoding the CGR staging system, navigating the ESRD and dialysis danger zones, and finally, cardiorenal combination coding rules. This is designed to move you from the underlying physiology straight into specific, high-stakes reporting rules. Let's get to it.
Section 1. The foundation of hypertension and heart basics. Let's establish our baseline by looking at hypertension's assumed direct physiological link to heart disease.
Right off the bat, this foundational width guideline is a massive time saver. It allows you to automatically assume a cause and effect relationship between high blood pressure and specific heart conditions, like myocardial degeneration or cardiomegaly, found right there in the I51.4 through I51.9 range. You link them using the hypertension code I11.9. The only time you don't combine them is if the provider explicitly documents that the heart condition and the hypertension are completely unrelated. Otherwise, the code just assumes that connection for you.
Moving on to Section 2, Staging Chronic Kidney Disease. Now let's zoom in on the kidneys and see how the guidelines meticulously categorize chronic kidney disease, or CKD. As you can see, the ICD-10-CM strictly classifies these conditions based on clinical severity, which is directly tied to the patient's GFR, or glomerular filtration rate. The codes move sequentially from N18.1 for Stage 1, steadily dropping down the GFR scale to N18.5 for Stage 5, and then culminating at N18.6 for end-stage renal disease. Notice how Stage 3 is actually broken down even further into 3A and 3B in the N18.3 subcategory. Oh, and here's a quick expert tip. If you ever encounter CKD in a patient with a kidney transplant status, you'd sequence the Z94.0 transplant status code alongside the appropriate N18 stage code to tell the full clinical story.
Section 3, the CGA staging system. Often physicians won't conveniently write out Stage 4 CKD in plain English. We have to decode it.
Enter the CGA staging system. The CGA acronym breaks down into 3 specific documentation elements that you need to be scanning for in the chart. First, C stands for the cause of the kidney disease. Next, G identifies the GFR category, and listen, this is your golden ticket because the G directly equates to the CKD stage we just looked at. And finally, A identifies the albuminuria category.
So here's how we apply it in the real world. If your physician's documentation simply reads CKD G4A3, you don't need to panic or query the provider for a stage. You just isolate that G4 component. That G4 translates straight to code N18.4, which is Stage 4 severe chronic kidney disease. It's really a direct one-to-one mapping once you know the formula.
Now for Section 4, ESRD and dialysis danger zones. We're going to escalate to the extremes here and tackle the strict coding rules surrounding ESRD and dialysis.
Okay, the absolutely crucial point here is understanding the inclusion rule. This is a vital override mechanism in the ICD-10 guidelines. Think about it. Even if a patient is explicitly documented at CKD stage 5 or any other standard stage, the very moment the chart states they require chronic dialysis, you bypass that stage code entirely. You map it straight to N18.6 for end-stage renal disease. Basically, dialysis dependence automatically elevates the coding severity to the absolute maximum.
Building on that, when you do assign N18.6 for an ESRD patient on dialysis, you absolutely must remember to pair it with Z99.2. That Z code captures the actual dependence on renal dialysis. Furthermore, if a provider's note is a bit, messy, and documents both a standard CKD stage and end-stage renal disease for the same patient in the same encounter, the hierarchy is crystal clear. Only assign N18.6. An ESRD diagnosis always overrides any standard CKD stage in the chart. No exceptions.
And here's a massive rule alert for you. Watch out for the AV fistula status trap. Often, a surgeon will create an AV fistula or shunt in a patient's arm in preparation for future dialysis. But whatever you do not jump the gun. An AV fistula created in preparation does not justify using the Z99.2 dialysis dependence code unless active dialysis has actually begun. Coding Z99.2 too early is a very common yet very avoidable error.
Section 5. Cardio-renal combination coding rules. For our final and honestly most important segment, we're bringing all of this together to synthesize the rules for complex, multi-system encounters.
So, when a patient is suffering from hypertension, alongside both heart disease and chronic kidney disease, we rely on the powerful combination category I13. Now, this code category is a total workhorse, but it requires support. When using I13, you also need to identify the specific type of heart failure using the I50 category. As a senior coder, you use clinical abbreviations to pinpoint your exact I50 code. For example, HFrEF for systolic maps to I5020.0. HFpEF for diastolic maps to I5030.0, and HFmRAF for mid-range maps to I5022. Or if they use the ACC/AHA stages. Stage A is Z91.89, Stage B or C is I50.9, and Stage D severe is I58.4. You use those exact codes to really bolster your primary I13 combination code.
Okay, before we sequence, let's anchor this with a rapid-fire true-false knowledge check from the explainer material. Ready? True or false? If a patient has CKD stage 4 and requires chronic dialysis, you code N18.4 and Z99.2. That's false. The inclusion rule mandates you use N18.6 instead. Next, true or false? An AV fistula creation always warrants a Z99.2 code. False again, only if active dialysis has actually started. Okay, true or false? HFpEF maps to I50.20. Nope, false. HFpEF is diastolic and maps to I50.30. Finally, true or false? A kidney transplant patient with CKD needs a Z94.0 code sequenced with their N18 stage. True. Always tell the full story. Okay, now how about sequencing? Imagine you're reviewing the history of present illness for a 68-year-old male presenting with exertional dyspnea, fatigue, trace ankle edema, and a home blood pressure average of 150/90. He has documented hypertensive heart failure and CKD. How do you accurately sequence this complex combination?
Let's look at how we build the complete coding picture. To perfectly capture his chart, you've got to follow a strict sequence. First, you lay the foundation with the primary code, from category I13, capturing the hypertensive cardiorenal disease. Second, you add your specific I50 code to identify the exact type of heart failure he's experiencing, like we just discussed. Maybe it's HFrEF or HFpEF. And third, you tack on the appropriate N18 code to definitively capture his kidney disease stage. Boom. 3 codes, sequenced perfectly, telling one cohesive clinical story. You know, this exact principle of comprehensive coding is echoed in the guidelines for secondary hypertension as well, as the guidelines explicitly state for secondary or complex hypertension, 2 codes are required. You're always required to code for both the root cause, the underlying etiology, and the resulting elevated pressure. You can't just code the symptom, right? You literally have to code the entire system. Ultimately, your power as a senior coding specialist comes from this exact mindset. You have to stop treating these as isolated diagnoses and start treating them as one massive interconnected system. Hypertension, heart function, and kidney staging are a trio that constantly influence one another, both in the human body and right there in the ICD-10 manual. So I'll leave you with this thought. Now that you know exactly how these codes communicate with one another, how are you going to audit your very next cardiorenal chart differently? Keep that in mind, stay sharp out there, and happy coding.